Okay everyone, so in this video what we're going to do is we're going to look at arteries, and we're going to focus on the arteries we see in the head and neck. Now when we look at arteries, what I want you guys to remember is arteries start with an A, so think of A like away. So the function of arteries, what arteries do is they take blood away from the heart, and then there are veins, which is in blue, is not shown here, but veins take blood back to the heart. So arteries are taking blood away from the heart. And the reason why I have this picture over here is that there is something called the right common carotid artery. And that one is right here. So right common carotid artery. And what's interesting about this is this takes all the blood up to the area that we're interested in. So we have a right common carotid artery. We also have a left common carotid artery, and that takes it to the left side. Now when you look at the carotid artery, there is something called an external carotid artery, and then there's an internal carotid artery. So think about the smaller one actually here is the external one, and it's external because it's, further out. Okay, so anything that's further out is external. Anything that's more deep in the body is internal. So this is an external carotid artery, and think about which one applies to the dental profession a lot more. Would it be the internal artery, which goes up into the brain, or do you think it could be the external carotid artery, which goes to, and you can see, right? You can see where it's going. It's going to the mandible or the lingual. It's going to the facial, and it's also going to the maxillary artery. So we are more interested in the external carotid artery. So again, here's the common carotid artery, and then it does branch off to external and internal, and we're going to look at all these different types of arteries. So facial artery is something we're going to be interested in. Lingual artery, which supplies the tongue, is another one we will look at. So internal carotid artery, external carotid artery. So this is the common carotid artery, and then it branches off to internal and external. And you can see here is the lingual artery, and think about where you think the blood supply is going. So it's going to the dorsal. The dorsal means the top of the tongue, and it's also going to the sublingual artery. So it's going to the floor of the mouth. And if you look at this slide here, lingual artery, where does the blood go? The blood feeds or supplies the tongue, so it goes to the tongue, and also the floor of the mouth as well. So the lingual artery is, you can see here in this picture, is actually very clear that you can see all the blood vessels, or arteries rather, are just going and feeding the tongue and also the floor of the mouth. When you look at the facial artery, okay, so again, we have the common carotid artery. Here's the internal carotid artery. Here's the external carotid artery. We looked at the lingual, which feeds the very bottom, the tongue. Then we're going to now look at the facial, and the facial starts right here. And look at the facial. It's basically covering almost the entire face. So it's supplying almost the entire face up until the very edge of the eye. So the facial artery ends at the inner corner of the eye, and what it does is it supplies blood to all the skins and muscles of the facial expression. But the maxillary artery, this is the biggest type of artery because there are 15 branches. So the facial artery supplies all the muscles of facial expressions. Remember, we looked at like how when we squint, when we open our mouth, those muscles that are innervated, they're innervated by the facial artery. But the maxillary artery, this is like the biggest artery because there's 15 branches, and I'll show you a picture in a bit. And what the maxillary artery does is it supplies, muscles of mastication, so muscles for chewing. It gives it gives blood to the teeth, supplies blood to the teeth, supplies blood to the nose as well. And the maxillary artery is a very important one because when we do local anesthetic, when we're trying to freeze some teeth, we have to reach out to one of the branches within the maxillary artery to freeze it. And that will make more sense as we look at the different maxillary arteries. So maxillary arteries, the one that I want to look at right now is actually, okay, let's actually start with this picture. So local anesthetic is a very important component to learn about in the board exam. And this is all the different blocks that are out there. And when I say blocks are different types of local anesthetic injections that are done to numb specific areas within the mouth. So if we look at this one, infraorbital block, infraorbital is, if I show you a picture, I don't have a picture here, the one that highlights infraorbital, but this over here, this foramen is called the infraorbital foramen. So if I were to inject my needle, the local anesthetic needle somewhere here, the infraorbital foramen, remember this opening has a lot of blood vessels, and when these blood vessels get hit with the local anesthetic solution, then all of this will be numb. So the upper lip and the anterior teeth, and even like the lower eyelid. The ASA, MSA, and PSA, so ASA, MSA, and PSA, this is all, again, part of the maxillary artery. So all of these are coming from the maxillary artery. So if I look at the maxillary artery, which is a little hard to see here, but here's the maxillary artery, you can see like how many branches they have. There's actually 15 different branches. So one of the branch is an anterior superior alveolar artery. And so let me show you that. Maxillary artery, anterior superior alveolar artery. So if I were to numb the anterior teeth, what I could do is I could just numb these 3 teeth, and to do so, I would have to put these arteries to sleep. If I wanted to numb the middle superior alveolar, or the middle teeth, so the premolars, I would have to numb or somehow get my local anesthetic in these arteries, which is the middle superior alveolar artery. And if I wanted to numb the posterior teeth, then I would have to make sure that I somehow hit the posterior superior alveolar artery. So here, this is the maxillary artery, and look at all those branches that it stems off. So it's hitting a lot of different branches. It's feeding a lot of different things within the maxillary, within the head and neck anatomy. So even the palate, if I wanted to numb the palate, the greater palatine artery could be hit and it would numb the hard palate. The lesser palatine artery, that one supplies the soft palate, which is further back. So here again, posterior superior alveolar artery. So posterior superior alveolar artery hits all the posterior teeth. Middle superior alveolar artery hits the middle, so premolars and possibly even the 6th. And then the anterior superior alveolar artery is reaching the anterior teeth. So if I wanted to numb just the anterior teeth, this nerve has to be affected. If I wanted to numb the premolar teeth, this nerve has to be affected. And if I wanted to numb the very back teeth, the posterior teeth, then the posterior superior alveolar artery has to be hit. And if you think about it, it makes sense, right? Anterior superior alveolar artery means anterior teeth. Middle refers to the middle teeth, so the premolar, and posterior refers to the back molars. So here again, we see the infraorbital artery, and when if I were to numb the infraorbital artery, it would numb the anterior teeth. So infraorbital artery hits the anterior teeth, the upper lip, and even the lower eyelid. And sometimes even the side of the nose. I've had this done before, and it feels really funny. We also have veins, and actually, sorry, before this slide, I want to show you this one. So this is a great slide because it tells you all the arteries that supply to different areas in the mouth. So if you wanted to numb the mandibular teeth, the bottom teeth, the nerve that you need to hit is the inferior alveolar nerve. Again, that stems from the maxillary artery. If you wanted to numb the maxillary molars, you need to block the posterior superior alveolar artery, which again stems from the maxillary arteries, and it goes to the back teeth, the upper teeth. If you wanted to numb the tongue for some reason, then you would have to aim at the lingual artery. Let's see here, soft palate, there's a lesser palatine artery that can, that supplies the soft palate. Floor of the mouth, the lingual artery supplies the floor of the mouth. So it's really interesting. I like how this slide has broken it down. We also have veins. So just like arteries take blood away from the heart, veins bring blood back to the heart. And so veins are in blue. And what I want you to draw your attention to is this place over here. And this is the pterygoid plexus of veins. That's what it's called, where it's like a mesh of veins, like just intertwined here. And the reason why I want to bring this into your attention is sometimes when we're doing a local anesthetic, what can happen is if we nick this area over here, then we can get something called a hematoma, which is a swelling and discoloration. So if you pierce a vein, maybe you have an improper angle, especially when you're doing a posterior superior alveolar nerve block, which is further back, blood will escape. And when blood escapes, you can get a hematoma. It's not necessarily harmful. It's just a swelling. It does go away, over time, but it may look alarming. And so the client may, not like it. But the reason why this happens is because you pierced a vein. So let's look at a possible test question. All of the following are branches of the facial artery except one. Which one is the exception? So this is the facial artery, and you can see it goes all the way to the inner corner of the eye. It's going, to the maxilla, is going to the mandible as well. So what is not part of the facial artery? If you said lingual, you would be correct, because lingual artery is a complete separate artery. So facial artery is a different artery, and a lingual artery is a different one. So all these ascending palatine artery, inferior labial artery, and submental artery, they actually are all branches of the facial artery, but the lingual artery is not a branch of the facial artery. It's its own branch. So therefore the answer is lingual artery. Let's look at another question. The posterior superior alveolar artery supplies blood to, give you a few seconds. So if you said maxillary, posterior teeth, and periodontium and maxillary sinus, you would be correct, because it only goes to the posterior teeth. The anterior teeth is for the anterior superior alveolar artery. The hard and soft palate, that's the greater palatine and the lesser palatine arteries. And the mandibular teeth and floor of the mouth, well, that is the inferior alveolar artery, which enters into the mandibular foramen. So the one that this one is the posterior superior alveolar artery, and you can see right here it is hitting the back teeth, maxillary posterior teeth, the top back teeth. Let's look at salivary glands. So salivary glands, there are three major ones that you should know. There is the parotid gland, which is a really big one. There is the submandibular gland, which is just under the mandible. And then there's the sublingual, which is just under your tongue. Okay, and all of these glands, they make saliva, and then saliva has to come out somehow and enter your mouth. So it has to go through a duct. And so what I want you guys to know is that the parotid salivary gland has a duct where it releases its saliva, and that duct could be called a parotid duct. It could also be called a Stenson duct. So think of past, pa for parotid, ST for Stenson. So that's how you can link them both together. This is all from student RDH, by the way. We have the submandibular gland. So the submandibular gland is right under the mandible, sub for underneath. Okay, so it's near the mandible. And then it has a submandibular duct, or it has a Wharton's duct. And again, how can you remember this? Well, the M in submandibular, flip it, and you get a W. The W is for Wharton's. Lastly, we have the sublingual duct, which is just underneath the tongue, and it does have many different ducts that come out and releases saliva into the mouth, and the ducts are called either sublingual ducts or the Bartholin duct. So sub has the word B for Bartholin. Also, you could think of subway. Think of like the subway where you go for lunch, and imagine that subway having a bar, which is kind of unique for a subway to have a bar. But then that's how you can remember sublingual gland has Bartholin duct. Now this is interesting. Even though the parotid gland is so big, it only releases or makes 25% of saliva. The majority of the saliva is made in the submandibular gland, which is like 60-65% of saliva. And then the sublingual gland, which is tiny, makes 10% of saliva. And we know that saliva is really, really important because it helps us, it makes it easier for us to swallow food. It helps break down the food. It helps us with swallowing food. It helps us with our speech as well. And it prevents our mouth from drying out, because we know if our mouth dries out, we're now at risk for bad breath. We're now at risk for cavities as well. Okay, so parotid glands, it's the largest salivary glands, but it only produces 25% of the saliva. And remember, past for Stenson's duct, because it's right near, and it actually opens right into where the maxillary second molar is. So sometimes when you look inside to someone's mouth and you see that little flap of tissue and that bump or flap of tissue is actually the parotid duct. I've had many students look in and they come and ask me, like, what is that? Like, why does that look so different or unique? And it's actually the parotid duct that you're looking at. Submandibular duct is right here, right at the floor of the mouth. You can actually see it. And this, by the way, is called the sublingual carbuncle. Sublingual carbuncle. And sometimes the sublingual carbuncle, you could get a salivary stone there, and it's obstructing the flow. The saliva can't come out because of that salivary stone. So there is treatment that could be done to get rid of that stone. So this is like a before and after. And then the sublingual gland, you can see there's so many different ducts that come out. And if I show you what it looks like, this is a sublingual fold, and that's kind of where the sublingual glands are too. The sublingual ducts also get released somewhere around here. The saliva from the sublingual ducts can come out over here. So question for you, the parotid salivary glands empty through the what duct? If you said Stenson duct, you are correct, because remember, past, P-A-S-T. Stenson duct is the name of the parotid gland duct. Let's look at the lymphatic system now. So the lymphatic system is really unique because what it does is it tries to kill toxins. So the lymphatic system, basically, it removes any fluids that leak out of your blood vessels. Those are called lymph. Those are called basically any fluid or plasma that leaks out of the blood vessels. It goes through the lymphatic system and it just kind of circulates in there, and it stops at a node. Like all these dots are lymph nodes, and it stops at a node. And what the lymph nodes do is that it's kind of like a checkpoint. They'll make sure if there's anything bad, they'll try to take it out. So it goes through many different checkpoints, if you will. The lymph, the fluid, kind of goes through all the different checkpoints, and it just weeds out all the bad toxins and stuff. So the lymphatic system is actually intertwined. So circulatory system and lymphatic system work together. And so this is your heart. And remember, the arteries take the blood away from the heart and the veins put it back in. And so as the artery is taking blood away from the heart, when it goes to the capillaries, there are lymph that comes out, and these lymph, they come out here, and the lymph node checks to make sure, like, if they're bad, they'll kind of like filter it out. And if it's and then it goes to another checkpoint, and again, if they see anything bad, it'll filter it out, and then it goes back into the veins and circulates within the heart. So it's intertwined within the circulatory, and the lymphatic system is intertwined within the circulatory system. So we have lymph nodes, which are those blobs that you see, and they filter the fluid. So anything bad, it'll take it out. So in the head and neck, we have many different lymph nodes. So we have the occipital lymph nodes, which is just if you think of the occipital bone that we have at the back, it's behind the ear, it's at the bottom of the head. And again, imagine there being lymphatic vessels all around, and then when the fluid goes into these nodes and then they filter out the bad stuff, they then go to another node, and eventually what it does, it goes all the way down into the deeper nodes. So it drains into the deeper nodes. We have the mastoid nodes, also known as the post-auricular nodes, and this is behind the ear. And again, all the fluid just goes all the way down to the back of the scalp. So any excess fluid just goes down back to the scalp and it gets circulated within the body. We have the preauricular, and remember, pre means in front, auricular means ear, so preauricular carotid node, and what it does is it drains from the anterior head above the eyes. So anything above the eyes, all the fluid will collect over here and it'll drain everything. We have the submandibular node, which is, so this is the mandible, it's just underneath the mandible, and it's below and behind the chin. Okay, so it is right behind the chin. And what does it drain? Well, anything from the gums, the teeth, and the tongue, they all go here and they get drained out over here. So the fluid from the blood vessel that comes out gets filtered in these nodes and then they go down. Then we have the submental. Submental, this is like think of the mental foramen we have in the skull. We have a mental foramen, which is the opening right near the chin, mental for chin. And they drain the inside of the chin, the inferior chin, also the floor of the mouth, so underneath the tongue, the tip of the tongue, and the lower incisors, they all go into the submental node and get drained out. So here is a picture, or actually a table, which is interesting because it summarizes it very nicely. So your gums, where do they get drained? The gingiva, it gets drained. So the gums, think about where your gums are. It gets drained in the submandibular or even the submental, because gums are everywhere over here. And then it even gets drained into the upper deep cervical nodes. So all the fluid, lymph kind of goes here, and then it goes down and circulates in the rest of the body. The palate, so the palate is at the roof of the mouth. And think about what's close to the palate. So actually with the palate, it goes straight into the, drains into the upper deep cervical node, so the upper part. The teeth, so there's teeth over here, and the teeth get drained into the submandibular and even the deep cervical node. So the teeth kind of, if they have any, fluid that comes out from the blood vessels, it gets into the submandibular or upward and actually deep cervical lymph nodes, and then it goes into the body. Anterior part of floor of the mouth, so the front part, so the front of the floor of the mouth goes into the submental, because submental is so close by, and then also the upper deep cervical nodes. And the posterior, the very back, drains into the submandibular, because that's closest to it. And you can see everywhere it's the deep cervical, right? So if it's not the submandibular, then it eventually goes to the deep cervical nodes and it gets flushed out. So here we can see it better. So submental is just underneath the chin. Oh, this was the mental foramen I was talking about. So submental is right here. This is submandibular node. I have a better picture here. Submandibular nodes. And we have the upper deep cervical nodes, so somewhere here, and then we also have the inferior deep cervical nodes. So let's say this was a question you got on your board exam. During an extraoral examination of a patient, the dental hygienist notes, okay, so this word is lymphadenopathy. I'm struggling too. Lymphadenopathy, and this basically means abnormal swelling of the lymph nodes. And so if you see this abnormal swelling of the lymph just beneath the chin near the midline, which lymph nodes do you think is involved? Retroauricular node, inferior deep cervical nodes, submandibular nodes, or submental? If you said submental, you are correct, because submental is the one that's just underneath the chin. And if I show you the picture again so we can review, let me pull it up. Here is the submental, so it's just underneath the chin. The submandibular is further posterior, is further back. The submental is just underneath the chin. So the answer to this question is submental. Okay, let's talk about root morphology now. Now, before we get into a deep root discussion, let's just look at the difference between an anatomic root versus a clinical root. So let's look at this picture over here. Anatomic root is actually the part of the actual root, basically the part that is fully covered by cementum, and it's the part that's inside the bone. But if you look at clinical root, do you see how it's higher like that? The clinical root See, the anatomic root actually starts right here where the root actually starts, but the clinical root, this is the part of the area that we cannot see. So the part that we cannot see is known as the clinical root. The part that we can see is known as, for example, the crown, the part that we can see is clinical crown, but the actual crown, including the part that you cannot see, so the gums are covering some of the crown at the bottom, that whole section is anatomical crown. But clinical crown is what you can see clinically. So clinically, this is the clinical crown. And then clinically, because we can't see this, we're saying that this is the clinical root. But anatomical is more accurate because it's telling you exactly where the root starts and ends. The root trunk is the distance from the CEJ to the entrance of the furcation. So if I were to color the root trunk over here, let me try to attempt to do that. This is the root trunk right here. In fact, I have a better picture in a different slide, so maybe I'll bring that up later. This area right here where the furcation is, so this area that I am trying to draw is known as the intercervical or intraradicular area. It's basically wherever you have a 2-rooted or even a 3-rooted tooth, the area between the roots is known as interfocal or intraradicular. So actually, let's look at this question. What term is used specifically for the bone between the roots of a molar? So if I were to draw a tooth, this part over here, what is this called? And if you said intraradicular, you are correct. Interseptal, so actually inter means in between, and radicular is between the roots. Interseptal refers to the bone between the teeth. So if I had like another tooth over here, the bone that's over here, okay, so the bone that's over here is known as your interseptal bone. So interradicular is right here, interseptal is the bone that is. There's bone over here, there's bone over here. So the bone between teeth is interseptal. CEJ, so cemento-enamel junction, is also known as a cervical line. So if I were to draw the CEJ, this part over here is my CEJ. And think of it, junction is where two areas meet. So this is where the cementum, because the root is covered in cementum, and enamel is right here, which is on top of the crown. So this is where the cementum and enamel meet, hence why it's called the CEJ, also known as the cervical line. Now the CEJ, or it's actually the cementum, is not smooth. The enamel is nice and smooth, but when you feel the cementum, when you feel the root, it's not as smooth. So the CEJ has the most proximal incisal or occlusal curvature. So where is it more curved? On which teeth? Incisors, canines, premolars, and molars, or molars. The answer is actually A, incisors. So let's look at it. If you were to take an Explorer and feel the bump over here, the CEJ bump here, it's more pronounced on the anterior teeth compared to the posterior teeth. In the posterior teeth, it's actually more flat, but in the anterior teeth, it's a lot more pronounced. So if you were in clinic, and you know how sometimes you have to feel for the CEJ when you're measuring the gingival margin line, you probably would be able to feel it more in the anterior teeth as opposed to the posterior teeth. Okay, so here's the picture. The root trunk is from the CEJ to the furcation. The apex is at the very tip. Peri-apex is whatever is around that apex. Peri means around, so the area around the apex, the area around the very tip of the root. Let's see what else we should know. So as we said, the CEJ has a rough tooth texture. And on the molars, the CEJ is a lot more straighter, so you can't feel it as much, but on the anterior and premolar teeth, it does have that bump, so you are able to feel it a lot more. And sometimes when you're feeling for the CEJ and you get that dip, sometimes you take your Explorer and it just dips in, that dip is known as your cervical enamel projection, or CEP, and that is present on the molars, towards the furcation on molars. So let's look at root shape. So we have to know which teeth have one root and which teeth have 2 or 3 roots. So I'm going to show you the dentition. And when you look at the dentition, when you look at the roots, I want you guys to note that in the maxillary, when you look at the first molar, second molar, and third molar, you can see it has 3 roots. Whereas when you look at the mandible or the mandibular teeth, it has 2 roots. And how can you remember that? Well, think about if you're hanging something from the ceiling, like let's say you're hanging a chandelier, you need more anchors, right? You need more anchors for it to stay up there. So that's how you can remember that maxillary teeth need more anchors because of gravity, right? It can fall down. So the more anchors, so that's why they have 3 roots. The more anchors, the better. The more roots, the better it stays up there. Another unique thing that you should know is that when you look at the second premolar, it has 1 root in the maxillary. Second premolar on the mandible has 1 root. But when you look at the first premolar, do you see how it has 2 roots in the first premolar in the maxillary and 1 root in the mandible too? So I'll show you guys a trick of how you can remember that. So the same thing applies for both ends. Okay, so we know that all the anterior teeth and the maxillary second and mandibular premolars have 1 root, but the maxillary first premolar has 2 roots. Okay, so maxillary first premolar has 2 roots. And how can you remember this? Well, this is something again from student RDH. So maxillary first premolar. If you take out the MA, you get X1P, and if you get rid of the 1 and make it into an I, you get zip, which sounds like sip. So when you think of sip, think of you sipping 2 root beers. Okay, so do you see how this kind of came about? It's really unique when you think of it. So max, you get the X from max. Okay, so X for max, so that's, you know, it's the top first premolar. You combine this, you get X1P. Take the one and turn it into an I. You get zip or sip, and sip. Think of yourself sipping 2 root beers. So now you know 2 roots in the maxillary first premolar. The maxillary molars have 3 roots because it needs more anchors. Mandibular molars have 2 roots. So let's look at a question that you could possibly get. Which of the following teeth is most likely to have a facial and lingual root? So facial and lingual root. Maxillary lateral incisor, mandibular canine, maxillary first premolar, or mandibular first molar. So maxillary lateral incisor, that only has 1 root. Only has 1 root. Mandibular canine, so mandibular canine again only has 1 root. Maxillary first premolar, well, maxillary first premolar, as we remember that trick that we just looked at, zip, has 2 roots. Okay, so this has 2 roots. And mandibular first molar has 2 roots as well. So we know it is not A and B because they are single rooted. Now what we have to do is figure out which one has facial and lingual root. If you look at the mandibular first molar, it's not facial lingual, right? If you look at the roots, the 2 roots, one is on the mesial, one is on the distal. But if you look at the maxillary first premolar, there is one on the facial and there's one on the lingual. So maxillary first premolar would be your answer because that's facial lingual. Do you see how 1 root is on the facial, 1 root is on the lingual? So you should really know where the roots are located because that might help when you have questions like this. So this is C because it has a facial and lingual root. What about this one? The root trunk on which aspect of the maxillary first molar is the longest? Which root on the maxillary first molar is the longest? So the answer is actually the distal, and it's really hard to tell, but the root trunk is the area from the CEJ to like the furcation, and the distance from here to here is actually longer than any other distance around. So that's why they're saying it's the distal. And I know that's really hard to see. I'm trying to see. It's actually hard to see over here, but it is the distal. Here's something else that's unique to know. So it's unique because furcations on mandibular second and third molars are slightly more apical than on first molars. So what does that mean? Furcations on mandibular second and third molars are slightly more apical than on first molar. See, this is the first molar. Do you see the furcation right here? It's quite up high. When you go to the second molar, the furcation goes a little lower, so it's downwards. And when you go here, it's even more lower, so it's more apical. So it's kind of sloping, right? It starts high, then it goes a little lower, and then the furcation goes even more lower. So that's a unique fact, that the furcations goes more apical as you progress down. Root concavity. So this is this depression that you see over here, very, very common in the maxillary first premolars. This is the area that we find a lot of burnished calculus. Burnished calculus means when calculus that you just remove the outer layer, but the inner layer of calculus is still left behind. And that's really hard to remove, and sometimes it's even hard to feel because it might even feel smooth. So this table over here, it actually tells you where do you have concavities, and you can see maxillary first premolar. Yes, there's a deep concavity, that deep depression that we see. It's really hard to remove calculus there. So it's a common area for burnished calculus. You can also see it on the distal of the maxillary first molar. There's again a common area for burnished calculus. So this is a great table I got from Darby and Walsh, and it outlines the concavities that we have in each of our teeth. And you can see some have no concavities, like the maxillary centrals don't have any concavities, whereas the maxillary first premolar, that has a deep mesial concavity. Here are some pictures of fused roots. So sometimes roots get fused, and the reason why they get fused and they're not separate is because during development it was really squished down there. They were squished, and so they had to fuse, and they formed one large tooth instead of like two different roots. And concrescence is when you have two teeth that are joined together by cementum. So that's what's concrescence. So C for concrescence, C for cementum. So they were fused by cementum. Sometimes we can get accessory roots, and so the maxillary first premolar, we know they have two roots, but sometimes they could even have three roots, where there's two on the buccal side or facial side and one on the lingual side. On the palato-gingival side of a maxillary incisor, sometimes we can see these grooves. These are known as a palato-lingual, palato-gingival grooves, and this is a great place for calculus to get formed, or it gets formed in here, developed here. And so now you have to think, okay, what's the best way to remove it? Because remember, you won't be able to use a regular curette to remove it. So maybe you want to use the toe end of a micro or mini or even extended shank curette. So what am I saying? What are these things? What is a micro, mini, or extended shank curette? Well, when you have tiny locations, or when you have furcations that you need to get into, this is their standard gracie. And you can see it has like a shank that is regularly sized, but sometimes it is sized. But if you want to get in deeper, you can get an after 5 curette. After 5 for after 5 millimeters. So your typical curette may just get up to 4 millimeters deep, or maybe even 5 millimeters. But if you want to get more than 5 millimeters deep, you need an after 5. And so an after 5 has a longer shank, so it's able to get in there more deeper. There's also a mini curette, and a mini curette is, if you look at this, the tip part over here, you can see that it is half that size. So it's a very small tip. And so these are great to get into the palato-lingual groove. So you can use the toe of that to get into the area, because it's so short. So mini is like this, and micro is even half of that, like it's even smaller. So that it might be even better to get into a very tiny place, and it still has a long shank. This is an enamel pearl, and sometimes enamel pearl gets confused with calculus because it feels like calculus. So especially if it's not visible on the radiographs, we sometimes are like, is this a calculus or is this an enamel pearl? And dilaceration, this is when they have a sharp bend in the root, and this is because the root was displaced when the teeth were forming. Okay, well that's all for this chapter.